For all the thyroid malignancies, needs total thyroidectomy. I mean, general statement, there are exceptions. Right? I will tell them later when we, as we proceed. Generally, they need total thyroidectomy. So surgery is total thyroidectomy. But if the nodule is less than 1 centimeter in size and it is classical papillary thyroid CA on histology, classical papillary thyroid CA on histology, no lymph node metastasis, no extrathyroidal extension, no metastasis, systemic metastasis. So it's a very good malignancy. Less than 1 centimeter nodule classical papillary thyroid CA, no lymph node mets, no extrathyroidal extensions, no systemic mets. Those patients can be offered hemithyroidectomy only. Right? Hemithyroidectomy only. So it is either total thyroidectomy or hemithyroidectomy, but to do hemithyroidectomy, patient should fulfill certain criteria. What is the problem of doing hemithyroidectomy for malignancy? Problem?
TS. It is TS is dependent.
Yeah. More the recurrence rate is high na chemical recurrence rate is high. There is a possibility of multifocality. There is a possibility, although now ultrasound says this is only nodule, the chance of having multifocality is there. Which one has more high chance of multifocality? Papillary or follicular?
Papillary.
Which one has a capsule? Follicular. So chance of having multifocality is more in PTC. Right? PTC compared to follicular. So one problem is that there's a possibility of missing another focus. And the other problem is, how do we follow them up? How do we follow up thyroid malignancies? With thyroglobulin. After total thyroidectomy, it has to come to near zero value. So if it rises, then you know there's a recurrence. You have to search for it. But is it zero? No. So there's a problem in following up. So basically, you can't go by single value. You have to go for rising titer. Exactly. You get what I say. So you get one value, then again after some time you will see. But if it's rising theta, then you have suspect recurrence. So there's a problem in follow-up, and there's a chance of multifocality. That is a problem of doing hemithyroidectomy. But having said that, guideline recommends if it is classical, less than 1 centimeter micropapillary CA, with no extrathyroidal disease, no mets, you can do hemithyroidectomy alone. Because prognosis is very good. Chance of recurrence is also very much low. What is the advantage of doing hemithyroidectomy or total thyroidectomy? All your complications are half. Recurrent laryngeal nerve risk, false risk is half. Hypocalcemia risk is half. Need of lifelong thyroxine is not there. Need of lifelong calcium is not there. All these things are half or zero. So that is the advantage. So you always give the option to the patient. If I was the patient, I will say, okay, get rid of my gland. Right? So you give the option to the patient. But this is not wrong, okay? Hemithyroidectomy can be offered. Right. Lymph nodes. Now, you can kill the lesita, but you have to get everything as one story. Lymph node. As I told you before, it is a predominant spread via lymphatics. Predominant spread is via lymphatics. So there is a place for lymphadenectomy. When you should do it. Is there a place for prophylactic lymphadenectomy? Yes, some people offer it because if the predominant spread is via lymphatics, you can offer the patient lymphadenectomy prophylactic lymph node dissection. How? In the neck, how many lymph nodes are there in the neck?
Six.
How many? 6 are there. That is level 1. Level 1 is level 1A, submental. Level 1B, submandibular. Level 2, upper cervical. Level 3, mid cervical. Level 4, lower cervical. Level 5, posterior triangle. 5A is supraclavicular. 5B is above the thyroid muscle. Level 6 is central lymph nodes, pretracheal and paratracheal. Level 7 is superior medius, which is not a cervical lymph node, but some people categorize it as level 7. 1A, 1B, 2, 3, 4, 5, 6 in the central compartment. What is the compartment which is commonly affected in thyroid disease? What is the closest?
6.
What is the closest lymph node group? Level
Pretracheal.
Good. Level 6, pretracheal and paratracheal nodes. Right. Level 6 node. So those who do not have lymph node involvement in the scan, there is a place for prophylactic central lymph node dissection. That's why I said plus or minus prophylactic. If you want, you can do it. You can avoid it also. The reason for prophylactic lymph node dissection is what? Because the predominant spread is valuable. Somebody can argue, if this is the predominant spread, why can't I get rid of this? Right? No, no. This is already done. This one. But for those who you offered hemithyroidectomy, will you offer this thing, prophylactic one? Why do you offer them hemithyroidectomy? Because the risk of recurrence and the metastasis is low, very low. That's why we ended up doing hemithyroidectomy only. So those patients you don't have to do prophylactic dissection even. Do you understand the concept? Risk का आडू इतना दाने बागे कहते हैं, मिशन prophylactic का common mode है, okay? Very important concept, okay? So plus or minus central lymph node dissection. But those who have involved lymph nodes, either clinically or ultrasonically. Clinically, there are palpable nodes which are hard in consistency. Parental FNA can prove whether they are metastatic. Or there are ultrasonically positive lymph nodes, large, spherical, absence of halo lymph nodes are suggestive of metastatic lymph node. So if there are clinical or ultrasonic lymph node involvement with the papillary CA, then it is not plus or minus. It is always plus. Central lymph node dissection has to be carried out. If it is not ultrasonically present or clinically present, you may do prophylactic central node dissection. But if it is positive, needs, remember not for hemithyroidectomy, okay? If there are lymph nodes positive, can you do hemithyroidectomy? No, that is then beyond criteria. So then they need center, not only center. When the central are involved, you have to remove the let's say the tumor is on the right side, you have to remove that side, lateral lymph nodes as well. Right? So central plus, we do central lymph node, it's mandatory. There you have to do central plus lateral lymph node dissections. Clear or confused? Anyone want me to repeat it? You want to repeat it? Right. Which part is not clear? Lymph node part. Now predominant spread is valley lymphatics. Right? So even if it is clinically not positive, there are no palpable nodes. Ultrasound also says no lymph nodes involved. You can do prophylactic lymph node, central lymph node dissection because the predominant spread is via that. Right? Prophylactic. Some surgeons do, some surgeons don't do. But if you have done hemithyroidectomy, that means the risk is very much lower. You don't have to prophylactically do. You can't rationalize your argument. Central lateral unknown, prophylactically do. Hemicare risk reason. Those who have involved lymph nodes, either clinically or ultrasonically, they need central lymph node. It's mandatory. It's not plus or minus. It's mandatory to do central lymph node dissection plus ipsilateral lateral lymph node dissection. Okay. About TSH suppression. Now patient has undergone this. Then next is TSH suppression. Is it important? Yes, because they are differentiated thyroid cancer. They are TSH dependent cancers. The growth depends on the TSH. So you have to keep the TSH suppressed. How do you suppress the TSH? By giving thyroxine. By giving thyroxine. Yeah? They give thyroxine high doses. What is the problem from there? These patients are usually given 100, 150. 150 dose. What is the problem with long-standing high dose? Osteoporosis. Yeah. So especially elderly patients, when you prescribe these high doses, you have to keep them on vitamin D and calcium supplements as well, because the long-term osteoporosis risk is higher. That is thyroxine supplement. Radioactive iodine treatment. All the TSH-dependent tumors, they respond to radioactive iodine. What do you know about radioactive iodine? Is it an IV drug, oral drug? Oral drug. Have you ever seen the iodine room at the cancer hospital? No? Bumper recording here? No? I put them there. Put them. Have you done something like that? Have you done something? Maybe it must be. What is the action of that? You take this oral drug, it has iodine, radioactive iodine, right? Iodine 1, 2, 3. 131. Iodine 131. It has iodine 131. So it is taken up by the thyroid gland. Then it emits beta rays. When there is emission of beta rays, it destroys the parenchyma. That is the rationale. So when it emits beta rays, it can damage. It can create problem to surrounding people as well, right? What are the other places in our body which has thyroid iodine receptors? What are the other places? Other tissues? Salivary gland and breast. So that's why breastfeeding is contraindicated when they are given iodine, because it emits through the breast milk. That's why it is, because it is taken up by the salivary gland. Also, there is a destruction of salivary gland as well. The common side effects of iodine therapy is xerostomia, dry mouth, right? Xerostomia. Take a again have some lime gun here. Lime is lime. That's what is recommended. Those who are paralyzed patients have nurses la mouth kya deni ko student nurse la sarta deni to hai na me aap kar mouth kya dena bora par works of the line tama dala takaboda or that stimulates, otherwise they get parotitis. So those who are on tube feeding, paralyzed patients who are on tube feeding, there is no salivation. When there is food in mouth only, they get the salivation. It is not there, they are dry. So because of the dryness in the mucosa and reduced salivation, they get parotitis. To prevent parotitis, when they give mouth care, they put lime in it. So that stimulates the gland, prevents parotitis. That is out of this topic, but common side effects of radioactive iodine is xerostomia. So action is that. So it is taken up by the gland and emits beta rays and destroys the gland. Now where is the gland? We have already taken it out. There is a chance of having residual tissues. Right. How do you know whether the patient has residual tissues or not? One thing is you can ask the surgeon. If surgeon says, no, I could not remove everything, it was adhered to the strap muscles, it was infiltrated to the strap muscles, so they have done maximum debulking only. Surgeon, it was adhered to tracheal cartilage and everything, so surgeon has done maximum. So if surgeon says there are definitive residual tissues, then you know. Otherwise, how do you know? You can do a scan. That is called pre-ablation scan. Before ablation, pre-ablation scan. Now to do this scan, to do this treatment, now I told you, iodine uptake is dependent on TSH. Now, patient is on thyroxine. What happens to TSH? Why do we suppress the thyroxine? TSH? So we are keeping the TSH suppressed to reduce the trophic effect on the gland. So can we do this treatment of scan? No. So before scan, we need to stop thyroxine, get the TSH into normal value, either to do the scan or therapy. Do you get it? Otherwise, your iodine treatment or scan will be ineffective. because your iodine uptake is TSH dependent. That's one option. You stop it, get the value into normal range, do it. Or you can give DNA recombinant TSH, keep the patient on thyroxine, let it be, give DNA recombinant TSH, and then do the scan of the therapy. So you have two options.
How long we have to stop?
At least 2 weeks. At least 2 weeks. Pre-ablation scan. Yeah, it's isotope scan. Radioactive isotope scan. But what we generally for scan we are using for 3 to 5 millicurie. I told you for treatment of toxicosis we are using for 7 to 50 millicurie. And for scan even very small dose. 3 to 5 millicurie body dose are there. For therapy we give about 70 or above millicurie. Very high doses for therapy. So if surgeon says there are residual tissues, you can straight away go ahead with ablation. If surgeon doesn't comment about it, you can do a pre-ablation scan, confirm there are residual tissues, and then go for ablation scan. Ablation scan is equal to ablation therapy. Your MCQ says ablation scan, that means therapy. Ablation scan means therapy, treatment. Pre-ablation scan is a scan. Okay? Although it's called ablation scan, it is ablative therapy.
So pre-ablation?
So if there are residual tissues, you go for ablations. Right? Or if you don't have to do any of these things, if initial assessment, if it's a larger nodule, let's say more than 4 centimeter nodule, with extrathyroidal extensions plus, or lymph node metastasis plus, anyway patient need radioactive ablation. Because you can't remove 100% lymph nodes. You can't remove everything. So patient anyway need ablation of radioactive treatment. And the therapeutic dose is 70 millicurie or above, depending on the metastatic burden. Now those patients has to be kept isolated. For a scan or a treatment of thyroid toxicosis, you don't have to keep the patient isolated. But for a radioactive treatment for malignancy, you have to keep that patient isolated at least for about 1 week at least. Ideally, you should measure their radioactive level before discharge. So keep them inside isolated area. Nobody can enter. Only the nurse can go there. But nurse also wearing lead apron. So for that matter, all the nurses in Cancer Institute, they are in a rotation in that unit. The main nurses are radioactivity nurses, they are in a rotation. Unless they are pregnant. Pregnant nurses are not in rotation. All the other nurses are in rotation. Because otherwise that person will get exposed to more. So they are using lead aprons. Patients have their own utensils, their bathrooms and everything. Nobody can use it. Recently they fixed CCTV camera because one patient was found dead. Because so they are kept isolated, and even after discharge, you advise them to not to go closer to a pregnant lady or children. They are the most susceptible people for about, let's say, I don't know exact duration, for some time. Right? For some time they pregnant. And those who are given this treatment, they cannot get pregnant at least 6 months to 1 year. Even males cannot father a child for 6 months to 1 year because they are excreted in semen. Therefore, these are the. So it can cause, it's oral drug, it can cause dry mouth, xerostomia. It is contraindicated in pregnancy and lactation. And patient has to be kept isolated at least for 1 week. Advise them not to go closer to children or pregnant ladies. And also, use absolute contraception at least for 6 months to 1 year. So this is about radioactive iron treatment. Any questions about that? We will understand the concept of pre-ablation and ablation. Follow-up. Follow-up. How did?
Sir, when are we going to start the pre-ablation and after the thyroid exam?
After thyroidectomy, generally after about, if you are planning a scan, after about 6 weeks only we are planning. So if you want to, let's say 6 weeks, 6 to 8 weeks. So if you are stopping this without your radiology, at least stop 2 weeks prior and then do. But Maharagava ideal therapy waiting list is so long, you will not get ideal treatment at least 1 year. Unfortunately. Right? The waiting list is huge. That is a problem. Either you get meds or something. Because that unit has only about 7 beds. Thyroid melanoma is not a common cancer, by the way. Not a common cancer. Follow up with thyroglobulin. So you monitor them with thyroglobulin maybe every 6 months. Thyroglobulin, which is the tumor marker. If it is increasing, you have to search for metastasis. How do you search for metastasis? Do iodine scan, whole body iodine scan. If there's uptake in the bone, then that means there's a bone met. Then what is the treatment? You can give the treatment therapeutic dose. I told them thyroid there are so many other things that you can do for bone mets. But generally what we do, that's what we do. Let's say a patient has metastatic thyroid CA from the onset. I told you 1% is metastatic. The patient comes with bone pain, or let's say 50-year-old patient comes with a pathological fracture of the femur. Female comes with a pathological fracture of the femur. What are the common primaries give rise to bone mets? You remember the diamond, I told you on that day, diamond. Thyroid, breast, lungs, kidneys, prostate. So female, no prostate, only other things. So let's say you diagnose, but after workup you find that this is a thyroid malignancy, small focus of thyroid CA. Unfortunately, the presentation is metastatic deposit in bone. Does this patient need total thyroidectomy? Right? Tell me, hands up those who says needs total thyroidectomy. Those who are saying they need total thyroidectomy. Sitaransi also says, Janit says. All the others are saying no total thyroidectomy. No total thyroidectomy. Total thyroidectomy is needed. Why? Because can we treat the bone met with iodine therapy? Having a no intact gland? No, you are giving a dose of 70. All the 70 will be absorbed by the gland. Gland will get destroyed, but it will not act on the met. Otherwise, you have to be very high dose, which is toxic, beyond lethal limits. Right? So even if it is metastatic thyroid CA, they need total thyroidectomy, get rid of the gland, then only you can focus on the meds. Your treatment will act on the meds. Otherwise, it will, because it has a lot of the iodine uptake receptors. It will be taken out of the gland and it will not be effective on the meds. So even if it is metastatic from the beginning, they need total thyroidectomy. So that's how we follow up. Any questions? Because if you understand this, the other things I can finish in 5 minutes. It's very easy. Any questions? Right. So that is papillary thyroid CA. Then follicular thyroid CA. Follicular thyroid CA. What do you know about that? Second most common age group is? Yeah. Gender? Females. Prognosis wise? Poor compared to PTC, but better compared to anaplastic. Way better compared to anaplastic. Right. And can it be diagnosed by FNAC? No, it can only suggest. So Bethesda 3, you can actually follow them up or do genetic studies. With Bethesda 4, to get the histological evidence, patient can be offered Hemithyroidectomy. If it says follicular carcinoma, you can remove the rest of the gland. That is called completion thyroidectomy. If you remove one half, because you are not sure about the histology, benign could be malignant, so you go for the patient hemithyroidectomy. And histology comes as benign, you just forget about it. If the histology comes as malignant, you may do a completion thyroidectomy. I will tell you why I said may. So treatment surgery wise, either total thyroidectomy or hemithyroidectomy. Hemithyroidectomy is the instance that I discussed a while ago. A patient comes with a solitary nodule. FNAC says Bethesda 4 follicular proliferations. So you don't know whether it's malignancy or benign adenoma. So you do hemithyroidectomy. Histology comes as follicular thyroid CTA. So you have two options, either to complete it, that is called completion thyroidectomy, or to follow up with hemithyroidectomy and follow up. So both are options. Similarly, if it is less than 1 centimeter, single focus with no extracardial extension, no meds, you can just follow them up. So guideline recommends to follow them up after hemithyroidectomy. If it is a single focus, less than 1 centimeter, no extracardial disease, no metastasis, you can follow them up. Otherwise, complete it. Similar to that. Chance of having multifocality is less compared to capillary because it has a nice capsule. Am I too fast or? Am I too fast? No extracardial extensions. Ultrasound. Go away ultrasound. So that is the problem. There is chance of you missing it. Ultrasound is operate dependent investigation. So you give the option for the patient. We can follow up. We can do the complete therapy. But generally, our minister of Sri Lankans, they say, no, doctor, again, do gland same happens to the breast. If I give the option to wide localization and mastectomy, most of the patients says mastectomy. Get rid of it. Most. That is the Sri Lankan mentality. When Ratal him kiya na tu I color ka thai color den aapke.
So in FNAC, we say that we cannot differentiate follicular carcinoma from adenoma. That's from type classification. Like it depends on the classification.
Yeah, it's type 4. Type 3 F. Type 3 we don't go by type classification now.
Eventually comes as we can differentiate FNAC, follicular carcinoma and adenoma from FNAC.
False.
Bethesda is like.
Even for Bethesda you can't. Suggestive of its eyes. You can't. So these are the indicative evidence. So you can do hemithyroidectomy for this as well. Is there a place of prophylactic lymph node dissection? Why did we do prophylactic lymph node dissection in the other case? Because it's a predominant spread. What is the predominant spread here? Hematology. So there is no place for prophylactic lymph node dissection. If lymph nodes are involved either clinically or ultrasomically, there is a place for central lymph node dissection plus lateral lymph node dissection. Right? If involved, there is no place for prophylactic lymph node dissection. Do you get it? Right. TSS suppression, is there a place? Similar. There is no change. Is there a place for radioactive iodine treatment? Obviously, because it's TSS dependent tumors, it will respond to radioactive. Similar. Same management, same principle. How do you follow them up? I told you, if you get the first part, it's easy to make it easier. But at the exam, you can't do these things because you will not be asking a compare and contrast. Right? Easy for me to teach. Then further cell carcinoma. Sorry. What has high chance of developing PTC than FTC. Papillary those who have minor lobe, long-standing minor lobe, the chance of developing PTC, papillary thyroiditis, can develop both, and this is common. Right. Hepatoid cell carcinoma is more or less equal to this. ඒක මම අපි මම කියන්නේ මෙනිකරට ට්‍රීට්මන්ට් කරනවා කියලා මේ නොඩිලා කියනවා මේක බෙටස්ටා 4 කියලා එනවා right අපි මෙනිකරේ අපි දන්නේ නැහැ it comes as malignant positive for malignancy so you have two options either to do a total thyroidectomy that is completion thyroidectomy or follow up with hemothyroidectomy alone. Because if it is less than 1 centimeter, other pancreas to be another. The data can be a karana pulwa. Yeah, obviously. Okay, clear? Yeah, that is आपको पात्र का लगा नॉन की हुई है. Hepatoid cell carcinoma is equal to this. Prognosis little bit lower compared to this, but otherwise everything is same. Everything is same, but generally they don't. Generally, total thyroidectomy is more favorable than hemothyroidectomy. This is same. There's no change. More or less same. Some people say it's a variant of follicular thyroid carcinoma. But that's the fact. That is the end of your differentiated thyroid malignancy. Then you come to undifferentiated. Metabolic thyroid carcinoma. What do you know about this? What is the origin of cells? C cells, or chief cells, or parafollicular cells. Parafollicular cells. That is the origin. What do you know about this? Anything else? Any other factors? Can you diagnose it by FNAC? What is the characteristic feature? Amyloid stroma. Amyloid stroma is a characteristic feature in metabolic thyroid carcinoma. It can be familial or it can be sporadic. It can be familial, it can be sporadic. Familial ones can be either familial metabolic thyroid carcinoma syndromes or it can be part of men. How many men are there? 3. Men 1, 2A and 2B. Which one is this? 2A and 2B or 1? How do you remember this? Men 1, 2A, 2B. 3 P's, 1 P, T, P. What are the P's? Parathyroid, pituitary and pancreas. Pituitary, you get all these pituitary tumors. Pancreas, you name any secretion by pancreas and put oma at the end. Insulinoma, glucagonoma, somatostatinoma, vipoma. Vipoma is vasoactive intestinal polypeptide oma. You name anything. You can put anything and oma at the end. It's a pancreatic tumor. Anything. So then parathyroid is primary hyperparathyroid. Right. So method 10 මොකක්ද ඔකේ? මෙතන එකක් මතක ගන්න. parathyroid. Primary hyperparathyroid method. සාමාන්‍ය method. Pheochromocytoma, metabolic thyroid carcinoma. මෙතන එකක් මතක ගන්න. මොකක්ද කියන්නේ? metabolic thyroid carcinoma. සාමාන්‍ය දැක්වෙන්නේ. Mucosal melanoma and carcinoid features. මේවා තියෙනවා. මොනවද මේකේ? පොදු කුලද?
පොකුල.
ඉස්කෝලේ අතර ඉගෙන ගත්තා.
ඡේද.
ඒ වගේ දැන් ඔයාලට අනන්ත වෙන්න.
ඡේද.
මහපොතුසාල කුඩා පොතුසාල
චේතනගුණක
So this is meant 2A and 2B. Right? So that's why in the history, in the long case, you asked about family history of thyroid CA because of this. And also, this can be familiar. There's familial peptide thyroid carcinoma also. And this is why you ask, another reason why you ask about family history of thyroid. Men not have no family history of sudden deaths, artery, hypertensive president, sudden deaths. It's a very vague question. Sudden deaths could be due to anything. So, few facts. It can be familial, it can be sporadic, it can be a part of this, can be diagnosed by FNAC, and what else about another carcinoma. Yeah. So treatment and prognosis wise is more or less equal to follicular thyroid carcinoma, but the order of occurrence is very low. So not a common malignancy. But prognosis wise equal to follicular thyroid CA. Surgery is always total thyroidectomy. There is no patient with thyroidectomy. It's always total thyroidectomy. Always. There is a place for prophylactic central lymph node dissection. If they are not involved, there is a place for prophylactic central lymph node dissection. Especially if it's bilateral tumors. Some patients bilateral tumors. There is a place for prophylactic lymph node dissection. Is there a place for thyroid suppression? No, because they are not TSH dependent tumors, they are not thyroid tumors basically. If they are not TSH dependent, is there a place for radioactive treatment? No. How do you follow them up? Can you follow up to thyroglobulin? What is the tumor marker? Calcitonin O, CEA. Those are the tumor markers. So generally after total thyroidectomy, we expect the calcitonin level to be 0. Right? 0. So if it is very high on follow-up, that means there are mets. The common site of metastasis is lungs. So you can either follow them up with calcitonin or CEA. So if you get MCQ saying CEA is a tumor, would have had a whole strand of water, but it's to make colorectal. Even you can colorectal to make a career. Would have had a whole strand. Up here, CEA is also tumor. For this, you can follow up with even single marking, but here you have to always go for rising theta because it is not 0. Because it is not a true marker of this. Okay, so you have to go for rising theta if you suspect this. So, any questions about this?
Their thyroxine dose is low than
This one?
Oh, yeah.
No,
We have to do that.
No, total to be done,
Yeah.
so you have to keep the
Size.
normal maintenance dose only. You don't have to keep them high dose. Our aim is to, on thyroid suppression, is to keep the TSH less than 0.01. Right? So suppress this, you have to give high dose. Actually, you don't have to keep this low always. If it is low risk, you don't have to keep this low. If the high risk, definitely you have to keep this, keep the level below 0.01. So if there is a patient with medullary thyroid, other than the treatment of this index case, if there is a patient with medullary thyroid carcinoma, you have to do the familial screening. Familial screening. If the patient with MCT diagnosed, medullary thyroid carcinoma diagnosed, you can either do the genetic studies. What is the genetic abnormality here? Red proton gene. Red proton gene is defective here. So if you can do a genetic study with the consent of the patient, if the red proton gene is defective, these patients are familials. Okay, that means family screening is mandatory. Okay, that family is a main family. If red proton gene is normal, so So then that patient in this case is a sporadic case, not a familiar case. Right? But to do this, you need to get the consent of the patient. You can't do genetic studies on patients without consent. You are here to workshop now. Who can I do? मागी genetic abnormality आती है को ज़्यादा एक्टिव नहीं रहते वो कोई अर्गीला आ रही है तो अगर कुछ हो नहीं without the consent of the patient you can't do genetic studies. So red proton gene abnormality. So if it's a men family, if it's a diagnosed men family with red proton gene abnormality, their family members needs prophylactic thyroidectomy. You don't wait until they develop parallel thyroid carcinoma. Okay? Not for now. Remember, for this is not true for all the parallel thyroid carcinoma. Parallel thyroid carcinoma with family screening positive for men needs prophylactic thyroidectomy. If it's men to A, they need prophylactic thyroidectomy before 5 years or at presentation. What do you understand by that? Before 5 years කියලා කියන්නේ ඒක අතේරන at presentation කියන ළමයා එනකොට ළමයා 7යි වල. දැන් මා අවුරුදු දෙකක් කරලා දැන් මා prophylactic thyroidectomy ඕන කියලා තියෙනවා. Then they need it either before 5 years or at presentation. Okay? If it's meant to be, prognosis is little bit worse than meant to A, they need prophylactic thyroidectomy before 1 year. Okay, infancy के thyroidectomy කරන්න or at presentation. තේරුණාද මම කියන්නේ? or at presentation කියන්නේ පහ පරක් වෙලාවක් නොකර ඉන්න එපා කරන්න. So that's the only indication for prophylactic thyroidectomy, I would say. Prophylactic thyroidectomy. Even at infancy they need it if it's meant to be family. Okay, so that's all about MCT. Then anaplastic carcinoma, very easy to teach. There's nothing you can do. Whether you do something or not, they are going to die within 6 months, maximum 1 year.
Suppressor.
100%
No, then you have to in this family get red proton के abnormality check करना.
Screen color.
एक ना consent जानना होती है. Positive, also positive नोरा कारण क्या बोला नहीं कि मैंने मगला में जो मैंने को है गिल्ला है.
Second, ammonium positive went on. Ammonium positive went on.
एक family के positive का इन्होंने कर लगा. red proton के abnormality positive का ठीक है, आपको भी prophylactic correct कर लगा.
What is the domain?
ඒක සර් percentage එකක් තියෙනවද? ඒ කියන්නේ generation in generation.
What is the word?
Sporadic के जानने को unless you do a genetic study. You don't know.
What is the
मैं अगर red proton के abnormality නැත්නම් ඊළඟේ family screening කරන්න ඕන ඊළඟ කට්ටිය කියලා. index case එකේ තියෙනවා නම් තමයි කරන්නේ.
What is the So inheritance pattern है. So inheritance pattern है.
proton gene එක abnormality තියෙනවා. very genetic නෙවෙයි.
Sporadically में mutation. So inheritance pattern है.
Sporadic के क्या है? ये बता सकते. You are married? Hope you get married soon. This is very important. Mom, what a is not a character from ADS man. So, Sartre coming on. That is where you are. Sartre in a bag or Sartre. So, anaplastic carcinoma is very easy to teach. they are going to die soon. Presentation is what is the general age of presentation? It is 7 to 8 decades. Or 6 to 7 to 8 decades. So they give a history of long-standing goiter with a recent rapid enlargement. Recent rapid get very rapid. 2 weeks, it gets bigger and harder. Sometimes it fungates and ulcerates and bleeds. Goiter එකක් තියෙනවා නාට්‍ය කෙනෙක් කරනවා 70 ක රාජ්‍ය කෙනෙක් goiter එකක් තියෙනවා එක පාටම වෙනවා ලොකු මුස්ලිම් තුවාලෙකුත් එක්ක තමයි. Total thyroidectomy, if you diagnose very early, which is very, very unlikely, you can do total thyroidectomy. Even after total thyroidectomy, the chance of dying is very high. Otherwise, we have limited place for surgery, very limited place for surgery. They usually come with respiratory obstruction, tracheal obstruction, because it infiltrated into the trachea. So in that case, you can do emergency tracheostomy just to save the patient's life. You can't let the patient die of suffocation. Very inhumane. Patient can die of other means. But suffocate very inhumane. So if the patient comes with tracheal obstruction, there's a basic emergency tracheostomy. Very limited flow for total thyroidectomy unless you diagnose very early. Very unlikely that scenario. So there's no place for lymph node dissection. There's no place for suppression. No place for this. No place for this. You don't have to follow up because they die. Clinic can get an enemy. What we do is we do when we come across this patient in our setup, we refer them to Maharashtra. Sometimes they will give radiotherapy to the gland. Not the radioactive agent, just external beam radiotherapy to shrink the gland. So that is about this. Lymphoma. Thyroid lymphoma can be a thyroid lymphoma only, or it can be a part of generalized lymphoma. It can be thyroid lymphoma only, or part of generalized lymphoma. So there is no place for surgery unless a thyroid lymphoma coming with respiratory obstructions or suppressive symptoms. There is no place for total thyroidectomy unless they come with respiratory obstruction, which is not the case usually. So you diagnose this by FNAC suggestive enema. If you want to diagnose lymphoma, you need a 4-needle biopsy or even open biopsy. If it is a thyroid lymphoma, treatment is chemotherapy and radiotherapy. There is no place for any of these. Sorry? We do not do biopsy for thyroid tumors unless we suspect a lymphoma. We don't do, because thyroid is a highly vascular gland. If you do biopsy, you can't control bleeding. So generally we don't do unless we suspect this. And also anaplastic you can do because it doesn't bleed. The gland is very fibrotic and cheese couple out. Ada student yang kalau ada sarcoma